point and everything going downhill, and they will very fast become manifest for the anaphylaxis. And Professor Sawa have mentioned that for the anaphylaxis, you have to act very fast to have immediate action, or the patient will going to lose. And in Taiwan as well, in China, we have a lot of so-called medical dispute, and the patient and the doctor argue about what is the medical legal problem, and then something will turn very bad. So firstly, we have to recognize if the patient already have a rapid onset of urticaria, we have to act first to know it's really due to the drug or really related to the other involved allergen or involved stimulant, right? And then for the delayed reaction, we have also involved the T cell. The T cell, you can see, firstly, very typical is the involvement of the skin. And the skin somewhat is become a popular change, and erythema and something coming out. And this is very similar to the virus infection. But if you look down for the epidermis and the dermis, you can see a single cell become a necrosis. And if you look up for the clinical, they will manifest as a bullous like assumption, or macular papular-like assumption, or maybe even they have become a pustulosis coming out. It's a tiny whitish papilla coming out from the erythema part. And if you look up closely, you can see this white pack is not due to the bacterial product. It's just only pustulosis due to the damage of the cell. So this is very typical for the T cell delayed type drug allergy will come out as a mild papulosis. And then if you do the patch test, firstly, in the first 48 hours, they will become like a papular change, and after maybe 96 hours, they will become pustulosis, because this is a very late reaction for the, involved by the T cell. So this kind of drug, delayed type drug allergy, that will involve the skin, and then the mild form maybe just on eczema, pustulosis, but gradually they will, if the symptom getting worse, and then also they will involve a lot of so-called stress, and that will cause a higher or eosinophil in the peripheral blood, more than 10%, and still they have like a vascular change. That is already become a moderate severe. And then for the most severe is Steven Johnson and also the TAM. I think this is very typical, and firstly, you see there have a skin rash coming out after taking the medication. And then this is like a target region. They will still like it just only have a peripheral elevation for the margin, and then they have a target necrosis in the center. And then they will become, gradually become bullous-like formation. It involve a lot of mucosal membrane, such as the oral mucosa and the conjunctiva. And then this mucosa even have a hemorrhagic spot coming out. So this is progressively developed like become a TANS. So for this kind of also a lot of skin manifestation like psoriasis, and also the bullous-like. And so in this drug reaction, you have to look up the dangerous symptom and the signs. Particularly, it's already found out it's already have a target region come out. And then for the necrotic sign, it's very. I would like to. No, it's not specific, but still, it's quite useful if you suspect for the patient with a lot of erythema change, already they have taken drug. When you perform the necrotic sign, you have to run very forcibly to and from, just only 1 minute, and then you got and not just only and become red, and then also some of the vascular will come out. So this is quite a dangerous symptom you have to look up. And then for the serious drug interaction, a lot of like the most common one is beta-lactam antibiotic. And for the other, will cause the delayed drug hypersensitivity reaction like drugs or 10 or Steven Johnson is a lot of anti-epileptic drugs like carbamazepine, allopurinol, or the other summer drug, sabalazine. Also, we have been reported on this one. It's very severe and very difficult management. And even we just only have one effective method is to prevention and also to act very fast to prevent the consequent very dangerous symptom. So for the epidemiology for the drug allergy, we don't have a very good data because this kind of symptom is come and go, and it's very difficult to do a larger survey. And a lot of risk factors you can find out the health-related factor. Previously, you think you are not allergic to anything, but when you're getting old, given the old age, or during a certain period like a pregnancy or after menopause, and then you find out somehow it is more sensitive to a lot of drugs, and then you got a skin reaction coming out. So the immunological change and the immunological aging will somehow cause become a risk factor for the drug allergy coming out. And then during the virus infection, all the other co-symptoms like autoimmunity also will cause the drug that were more sensitive to your body. And then the other is a genetic risk factor. We cannot avoid to know it's particularly for the level is any difference for Caucasian and the Asian Oriental people. Because for a lot of genetic risks, some of the drug was very effective in Oriental people, but not have a good use in Caucasian. Particularly for the drug, the treatment for the lung cancer or treatment for the breast cancer. Then the so-called genetic susceptibility as well as for the genetic subtype that were more effective to drug. Particularly, if you look out for the carbamazepine, allopurinol, or some of the drugs that were treated for the virus that causes stress. And then this study is coming from Taiwan, and that using the Steven Johnson syndrome and the test for the genetic test. And then we found the HLA-B51, they have 100%. If they already have a Steven Johnson, we found that it's 100% positive for HLA-B51. And then for the tolerance one, it's just only below 5%. So it's a very dramatic difference. And then this has more studies come out for the allergy noise, and found that the Chinese around the Taiwan and the south part of China, even for the Singapore and for Hong Kong people, they also have a genetic susceptibility that will cause the Steven Johnson syndrome. So a lot of drug allergy will depend on genetic factor. So how come the drug will have an immunological reaction that causes the drug allergy? There were several, and also very, actually it's very complicated to know how they interact. But if we divide it for the immunopathogenesis mechanism for the drug allergy, we can divide it in 3 parts. One is hapten or prohapten, or using the so-called PI concept. Firstly, for hapten, that means that if we apply the drug and that is reactive, that can directly bind to the protein, it's called hapten. And then if the drug have to be metabolized, become a transformation, then the metabolite interact with the immune reaction. So this is the prohapten. And one of the small drugs that can directly binding to the immunological receptor that they call the PI concept. So I make it simple with the hapten drug that is directly can bind to the immunobody, or they can directly bind to the LGLA molecule that cause the cell to become activation. And this activation they will go through for the other HLA different and then attack the organ, such as in the skin or in the mucosal membrane, or even in the liver or like a spleen and a lung. Because some of them is thinking about if you have experience to do the bone marrow transplantation, you will find out a lot of people, if they got a so-called GVHD and graft versus host disease, a lot of neurological mechanisms for drug allergy and the GVHD were very, very similar. It also worked on the MHC class 1 and class 2. So this is for happen. That means that the drug have to be metabolized in our body and then become a reactive drug that act on the protein that causes the hypersensitivity reaction. Such as you will use the sulfur drug. Sulfur drug have to become a metabolite by the liver as liver enzyme, and then this metabolite will actually conjugated to the MHC component or directly bind to the cell that causes the